If anybody has a specific question in the middle, you're free to interrupt, and I will try to answer your question. And otherwise, certainly at the end, we will have time for discussion. So this is a talk about palliative care, which is probably at least a concept that everyone is familiar with, and something that is extremely important to the care of many patients that everyone of you in this participating today will eventually cross paths with either this in a patient or a family member or both. So next slide, please. Okay, so many people think of palliative care in different ways, and and people have different concepts in their mind. Some people think it's What happened? Some people think it's hospice. Some people think it's different things. So I think it's good to start with a definition that we're going to use throughout this talk, and that is really the World Health Organization definition of palliative care, which I think is pretty good. So I'm just going to read it to you. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. Next, please. So, healthcare treatment, including interdisciplinary end-of-life care and consultation with patients and family members to prevent or relieve pain and suffering and to enhance the patient's quality of life. And that can include hospice care, but it does not need to include hospice care. And I'm going to show a slide that's going to show you the very important differences between palliative care and hospice care. Why is it interdisciplinary? Because palliative care is complicated. It involves medical treatment. It involves social aspects of the patient's care and goals of care and many other different things that it takes a team to really help the patients through this process to obtain physical and mental relief for their suffering. Next, please. Okay, so here's a very busy slide, but basically it's pretty easy to understand. And you can see it was in the New England Journal, Dr. Morrison, who's currently the chairman of the Department of Geriatrics at Mount Sinai and was my former fellow, believe it or not, when I was at Mount Sinai. But none of this has changed since 2015. So I think it's still a really good slide to go over. So if you look at the differences in what kind of care it is, it's not that dissimilar in terms of what the model is. It can include many different team members. And the goal is the same, to improve the quality of life and relieve both physical, emotional, and spiritual suffering. Eligibility is completely different between the two. So generally speaking, to become eligible for hospice, the first question that is asked is, do you think this patient or this person will be alive in 6 months? So if the disease that you're referring the patient to hospice to is generally would have a course of 6 months or less. And that is what will bring the patient to Medicare eligibility to join hospice, which is really a Medicare HMO, and all the benefits that you have under Medicare will fall into this hospice benefit. So that's what becomes very challenging, because if it's cancer, we often know if somebody has metastatic cancer all over their body that they're probably not going to make it 6 months if they're failing treatment. But some diseases like heart failure or dementia may be very much more difficult to put your finger on the 6-month mark for prognosis. If you make a mistake and you say that, yes, I think it's 6 months and the patient actually lives more, you're not going to be arrested, and the patient may even be re-enrolled in hospice, but they will be reevaluated after 6 months to see where they stand. And some patients actually do come off hospice and continue to live. But palliative care doesn't have that kind of criteria. Anyone who's suffering, regardless of what stage of their illness, and whether or not they're opting for prolonging their life or not, and they're even under active medical care, if they're suffering, they are entitled to palliative care. So now you will see that in many oncology offices, for example, there are palliative care doctors. So that's a very, very big difference between the two. So where does palliative care occur? Palliative care most often occurs in hospitals. We have palliative care physicians. It would be great if we had more palliative care physicians doing home visits and in outpatient settings. I find that's a challenge, but there is to find those people, but I think it certainly would be helpful. And hospice really is a home benefit. The only time that you wind up in the hospital when you have hospice is really if you're at the end of your life and you have uncontrolled symptoms that can't be controlled in the home, or there is nobody in your home to help you out with your end of life. But mostly hospice is a service at home. Hospice can also be in nursing homes for patients. So the difference in payment, is probably the most boring aspect to us clinicians, but we need to understand it. So as I said earlier, hospice is a Medicare benefit, and palliative medicine is actually covered under the physician services under Medicare Part B, or depending on where you are. It's like seeing any other doctor pretty much. Okay, so next slide, please. So I'm trying to make the point, and I make it many different ways today, that palliative care is not mutually exclusive from disease-modifying therapies. So someone who's undergoing active cancer, chemotherapy, or surgery, or anything else can also have palliative care. And I think we really fall short in offering patients that additional help in managing their illnesses, and that's why I'm stressing it so much. Next slide, please. So actually, there is a public law that went into effect regarding what I just said in 2011, that it actually is a law that doctors, attending physicians are required to offer terminally ill patients information and counseling regarding palliative care and end-of-life options. However, we don't always see that this is happening, as I'm sure many of you have had that experience. Okay, next slide. So the law goes on to say that even if a patient doesn't have the capacity to understand what you're offering them, then you must offer it to their healthcare proxy or their surrogate. Meaning you must offer palliative care consultation and services. Next, please. So what is the point of this? The point of this is that we want to make sure that patients are fully informed and empowered to make choices consistent with their goals of care, wishes and beliefs, and to optimize their quality of care. It is not intended, this law is not intended to limit available options. And I think that's a very important point, because whenever people hear palliative care or hospice, well, really palliative care, would you like a palliative care? They think they're dying, or they think that you're giving up on them. And it really is not necessarily the case at all. And I think people need to be empowered, and doctors that are taking care of patients are often very busy and don't come in and sit down and really have these goals of care discussion. So once you've had a conversation about, do you want to be resuscitated or not be resuscitated, that's the beginning of the conversation. That's not the end of the conversation. The goals of care has to do with every other treatment that patient is undergoing. And, what is it that's important to them? what are their value systems? And most of the time, interns and residents are not trained to go through that, and nor do they have the time to go through it. And it does really require a team, and hospice often comes in with more of a team to have that kind of conversation. Although I do think that it's really important for primary care doctors in the community to actually be having these conversations. And this should not be, conversations that are occurring in the last minute when someone's, really critically ill in the hospital and they're not with doctors that they are familiar with. So, for example, today I saw a 96-year-old woman in my office who was fine. She was, her usual self, but she happened to say to me, if my pacemaker doctor said, I need to get a new pacemaker. And I'm thinking, I don't want a new pacemaker. I'm 96. What do I need that for? So that opened my eyes to a whole conversation of, well, what kind of care would you want? If your heart stopped at home, do you want, the ambulance to come in and resuscitate you? And the daughter chimes in and says, oh, well, we don't make those decisions. The rabbi makes those decisions. And I said, no, the rabbi makes those decisions only if the patient wants the rabbi to make those decisions, not if you want the rabbi to make those decisions. So in the end, we ended up with a MOLST, and the patient wants limited aggressive care. And she was completely mentally intact. And it really has nothing to do with the daughter's wishes or the rabbi's wishes. It has to do with the patient's wishes. And if left unattended to today at such a time that she would not be able to express herself, then her treatment would not be consistent with her goals of care. So it's really important, actually, for people in the primary care setting to start these conversations and not wait till the critical last moment of someone's life. Okay, next, please. So as I said, this law is not intended to discourage conversations with patients about palliative care. It is appropriate to discuss palliative care earlier in their disease progression. And appropriate is defined as consistent with applicable legal, health, and professional standards. So, and you want to understand the patient's known prior wishes and beliefs when you're helping them through this conversation. Next slide, please. Well, I think we beat this one to death already, that this really is an obligation of the team taking care of the patient to offer these services when someone's in the hospital. Generally speaking, that doesn't happen as often as it should. Next slide. Thank you. So why are we saying this, and why am I beating this to death? There's a lot of research around this, and one of the most, so for example, I'm just going to point to some articles that although they're not recent, nothing has really changed in this regard. So approximately 1/3 of patients with advanced cancer had end-of-life discussions with their physician in the last 4 months of life. That's a very low percentage of people who are dying of cancer. And we also know that patients who are enrolled in hospice, it's often within a day or two of their death, which is, as I said earlier, hospice is a benefit you can offer somebody 6 months before their death. So we're really not even enrolling patients in hospice soon enough. Okay, another study showed that 83% of patients age 60 and older with limited life expectancy wanted to discuss this. So we often shy away from these conversations because we think the patient's going to get upset by the conversation, or the daughter or the son says, so don't talk to my mother about that. That will really upset her. And in fact, that's really not the case in studies, that people do want to talk about that. And patients are actually protecting their children and saying, I don't want to upset my daughter. That's why I didn't say anything, but they do want to talk about it. And we're going to go over ways open up the conversation and to figure out how far a patient wants to go in the conversation and when you should stop. But I think there are ways to, and we will learn them in this talk, how to start a conversation and see where a patient wants to go with it. Next slide, please. This is a very important landmark study that was done by somebody named Tamel on lung cancer patients. And the study actually showed that patients who had palliative care along with their cancer treatment lived longer. And why do you think that is? Does anybody want to say anything? Have any idea?
They're probably getting better care. They're
Well,
getting
better cancer care or
no. I mean, like, you know, you have somebody who's looking after your nutritional needs. You have somebody who's looking after your depression. You have somebody who's interested in making sure you have social connections.
That's correct. So if people are in less pain, you know, are able to eat better, are less depressed, they are going to live longer with their cancer. So that is true. So I think, you know, I think you got the points. Very good. I don't know who spoke, but very nice. Okay, next slide, please. So what's a good death? So, you know, as a geriatrician, I think people live very long, and I have patients in my office for many, many years, but I think sometimes I feel good. You know, I'm never happy when my patient dies. And it's always a sad occasion, but sometimes I feel gratification if I feel that I help them through the process and their families through the process by, you know, relieving pain and suffering, giving people a chance to come to closure with each other. I think one of the most difficult things is when a patient dies and there's still conflict and people don't have closure. And then those left behind are having a very hard time with their bereavement. So I think there is such a thing as a good death. And this is what I think is involved in a good death. And this is where palliative care can be helpful. So pain and symptom management, a clear decision making with physicians on goals of care. And I want to be very clear that goals of care is a conversation that can occur every day, especially when someone's in the hospital, because the situation for that patient can change every day. So today you come up with one plan. Well, that's a very fluid plan. And tomorrow you may have another plan. So I think, you know, it's not like, okay, we've made a plan, that's the end of it, and this is the plan for this hospital. It's a very fluid, ongoing conversation. What are the goals today? What are the goals tomorrow? May be very different depending on how today went. So you want to prepare people to understand the course of their illness and plan for events following that person's death. It's important for the patient who's passing, if they are mentally intact, to come to closure with their family members, their loved ones, to review things and to say goodbye. It's also a time for them to make any gifts, contributions, etc., and for the family to affirm that person is a whole person. And I think many people miss that opportunity because doctors are afraid to say, I think she's dying. She may, you know, we don't have a clear picture where we say within 2 days, 3 days, but we could say that we think they're at their end of their life and it's time for you guys to get together, you know, come and have some conversations about it. But I want to be very careful not to say, I never tell anybody you have 2 days to live or, you know, 2 months to live, because I'm never right. There are ways to prognosticate, but it's a very big challenge. And I don't think you have to put it to that kind of a timeline. Any questions before we go on? Okay, so next slide, please. All right, so how do you know if someone's we're going to go over criteria for 6-month prognosis for hospice. And this question, the second question, would you be surprised if the patient passed away within 6 months, is the question that you're supposed to ask yourself when you want to offer someone a MOLST, which is medical orders for life-sustaining treatment, which we are going to go over in this talk also. So I'm going to just go to the next slide for now. So how do we determine terminal illness? So I'm going to give you two cases here. Does a frail 100-year-old patient with dementia meet the standard? What do you think? Anybody want to come up with an answer? Do you think every frail 100-year-old patient dementia has a 6-month prognosis? I'm seeing a no from someone. Does anybody think yes? Well, the answer is we don't know. And that's one of the big challenges and why so few patients compared to cancer patients have been on hospice. So the next one, how can you determine the time frame for terminal illness? So it's a lot easier and there are more benchmarks for things like advanced heart failure and COPD. And we're going to see those criteria in the next few slides that hospice uses to evaluate whether someone has a 6-month prognosis. Next slide. So CMS Medical Criteria for determining 6-month prognosis for dementia. So you have to meet 4 out of these 6 criteria to be eligible for hospice, because if you're at this point, you probably have 6 months to live. But that's not 6 months or less, but you may live more. So someone who can't really do their own basic activities of living, like walking, dressing, bathing, they're incontinent, they don't communicate anymore, and they're basically bedbound. So it's really someone who's at the end stage of dementia, not walking around confused, but really non-ambulatory and in bed. And those are the ones that are going to, they're not going to die. You don't die of dementia. So a patient like this is going to end up dying of either a bed, most likely pneumonia. Okay, next slide, please. So there are more. You also have to have one of the following criteria in addition to the first slide. So as I said, infection, either aspiration pneumonia, UTI, sepsis, advanced bed sores, recurrent fevers, you can't maintain your caloric intake, etc. Okay, so it's really that point in dementia. And what's interesting about dementia is the progression for any patient is unpredictable. Some patients, you make the diagnosis when they're confused and they progress to this stage 7, which is what this would be, in a year or two. Other patients progress more slowly and can be demented for 10 to 15 years. So it's very challenging. Next slide. So heart disease is a little bit more easy. So patients optimally treated with diuretics and vasodilators or has medical contraindication or refuses them and has an ejection fraction of less than 20% with recurrent heart failure at rest and significant symptoms. So this is a little bit easier than dementia to say, I think my patient deserves hospice and has less than 6 months to live. Next slide, please. Okay, I didn't think that was my next slide. So what kind of pain management do palliative care doctors do? Pretty much any kind. There's acute, chronic cancer pain, non-malignant pain, neuropathic pain, etc. And there may be some perception that pain sensitivity decreases with age. It does not. And we often are afraid to give elderly, frail patients sufficient pain medication. So we often want to be backed up by palliative care doctors to help us with that. And then there's, the double effect. So you give somebody something for like even morphine for pain or difficulty breathing and heart failure. You can use morphine, and then they die. But that's not necessarily. But you are not killing them. You're treating their pain, and that is the natural course of their illness that they subsequently pass. But you're not. But you're just trying to give them enough medicine to control their pain. So there's a little bit of a difference there that we could talk about more later if I'm not making myself clear. Okay, so next slide, please. So palliative care also, as one of the other doctors or students listening correctly said, palliative care is important for controlling non-pain symptoms, including agitation, anxiety, delirium, depression, constipation, nausea, dyspnea, fatigue, wounds, and spiritual pain is extremely important. Next, please. So in 2010, which is now more than 17 years ago, the Family Health Decisions Care Act came into effect to create a legal mechanism for a surrogate to make decisions for incapacitated patients who don't have a healthcare proxy. So that's very important because many people have never appointed a healthcare proxy. So being able to use a surrogate was a big step forward in helping patients through this end-of-life decisions. And if there is no surrogate, and we do have patients who we call orphan elders that have just nobody, decisions can be made by two concurring attendings. Next slide. Okay, so we just said that. Okay, next. Okay, so there's also guardians. So some people have guardians for many years for whatever various reasons, they mentally incapacitated or whatever, or they chose to have a guardian instead of a family member make decisions for them. And then there's a hierarchy of who you would go to for surrogate decision making by law. So first you would approach a spouse, then an adult child, and then a parent or a sibling or a close friend. And you keep going down the line if somebody refuses and doesn't want to participate in the decision-making process. Next slide. So what can a surrogate decide? It's not exactly the same as what a healthcare proxy can decide. So a healthcare proxy can make decisions about pretty much everything except nutrition and hydration. So if on that proxy form you don't specifically state my proxy knows my wishes about nutrition and hydration, you can actually end up with a feeding tube, because that's when that law, the healthcare proxy law, went into effect, which was before the surrogate law. The church actually fought and said everyone has the right to nutrition and hydration. So if you look very carefully at the healthcare proxy form, there is a section there that says, if you want your proxy to make decisions about nutrition and hydration, you need to state that right here on the form. And many people getting healthcare proxies overlook that. So I'm pointing it out so that you can address that with your patients and make sure that they actually fill out that form. The other interesting thing of that piece on the form, the other interesting thing about the healthcare proxy form is that you can appoint somebody and never tell them, and they don't even know you're a healthcare proxy because they don't need to sign the form, which I think is a big flaw and a problem with the proxy form, because there's no point in having a proxy if you're not going to discuss your beliefs with that person. Because what will happen if you don't have that conversation, if they agree to be your proxy, they're going to have a hard time knowing what to do, and they're probably going to default to what they think is best rather than what you would have wanted, which is not the intent of the law for a healthcare proxy. So when you have a surrogate in front of you, you try to give them all the information that you can. to help them make the best decision for that patient. Next slide, please. So, I'm sorry, I keep getting paged. Okay, so what is capacity? So when you're trying to figure out if you want your patient to make a decision, or you need a surrogate or healthcare proxy, you have to think about what you're asking. So a person who may not know that, it's December, it's January 11th, 2021, doesn't mean they don't have the capacity to say, I don't want to be on a ventilator. Does everybody understand that concept? I can't see anybody, but if any,
Yes.
Okay, good. So it's decision specific. So if you're asked, and how do you determine that? There are many ways that we do that. One of them is to say, if you're talking, let's say, about resuscitation, intubation, what did I just say to you? Can you repeat what I'm asking you? And what do you understand about it? And then you can check for consistency by coming back a half hour later, a day later, and saying, let's have this conversation, and see if their answers are consistent over time. So just keep in mind that you don't need to do a mini mental status that's not how you determine capacity. It's decision specific, and you have to look at what you're asking and the person's understanding of it, and their consistency in answering you the same way over a short period of time. I think that's very important to understand. Next slide, please. So this summarizes that. Can the person make and express personal preferences? Can she or give reasons for this choice? So if you're asking somebody, you're saying you need an appendectomy, and the person says, oh no, I don't want that. I don't want a scar. That's not necessarily a rational choice. So you want to hear answers that are consistent with what most rational people would answer. And so you need to be a little bit wary if you get somewhat of an irrational answer. So you have to think about that, and you have to make sure that that person comprehends the risk, benefit, and implications of their choices, which you think may not be so rational. So, for example, we had a Holocaust survivor who had kidney cancer, and he needed to have a nephrectomy. And he was otherwise healthy, and he kept refusing the nephrectomy, and we didn't really understand why. And finally, it came out that when he was in the concentration camp, he had witnessed a medical experiment where they removed somebody's kidney without any anesthesia. So he was, his reasons for not wanting it was completely psychologically based, and not based in his own, health. So it's important to really try to drill down to why people are making choices that you may perceive as not being in their best interest. Next slide. Okay, so there are standards that have been set up for surrogates to make decisions, and we're going to go over those quickly now. So decisions should be made in accordance with patients' prior expressed wishes, including religious and moral beliefs. So that's important. That's why people need to talk to each other, and that's why doctors need to talk to their patients. And for getting back to the example in my office today, my patient was less religious than the daughter, and had we not had this whole conversation today, the daughter would have chosen to intubate her mother at all costs. So this is very, very important. Okay. If you don't happen to know and you never had the conversation, you're supposed to act using the best interest principle. And in order to do that, you have to consider the dignity and uniqueness of the person, preserve life, restore health and function, relief of suffering, and their values, and think about that person's values and what they would have wanted more than what your values are. So try to think back on anything. Like we often will ask somebody, did you ever watch a TV show where, you know, your mom said something about, you know, a medical show or something about that, you know, I never want to live that way? Or did she say, you know, I always want to be alive at any cost? So you have to try to drill down to get to those values that that patient had when making your decision as a surrogate. Next slide, please. This is just the definition of life-sustaining treatment. I think that most of you probably know what that is. Any medical treatment or procedure without which the patient will die within a relatively short time, as determined by the attending physician to a reasonable degree of certainty. Next. Okay, so what do we do? How do we have this conversation? Well, we don't, you know, it's not a curbside, bedside conversation. It's something that we like to set up. It doesn't have to take an hour, but it should be in a calm, quiet place, not in a hallway. So you set up a meeting and who you want to be there, and you invite patients, families, and maybe the social worker, the care manager, the patient's outpatient doctor, or whoever else you think would be helpful. Okay, next slide, please. So this is what you start with. What is your understanding of your illness? You don't start, well, you have advanced cancer, and so we're having this meeting today. No, what is your understanding of your illness? What information would you like about your illness? And you may get cut off at that point. I don't want to know anything. Talk to my daughter. So this is how we have this sort of stepwise conversation where we're not, you know, where the daughter says, don't say anything. You can say, well, we have to have some kind of conversation. So let's see what your mother wants to hear about. So you start this way. What do you think you're in the hospital for? I don't know, and I don't want to know. Or I think I have cancer. You know, it depends. You progress depending on the answer that you get. And these are very generic questions that you can use. If your current health deteriorates, what are your most important goals? What worries you about your health? How much does your family know about your priorities and wishes? So I think these are really good questions. Next slide, please. So this is really not necessarily, as I said, it's a fluid thing. It's not one conversation and we're done with this. Circumstances change, goals of care changes, etc. So you just have to keep in mind that it's fluid. Next. So here are just some funny pitfalls. A resident walks into the room looking preoccupied and says, Mrs. B, according to hospital rules, I need to discuss your code status with you. Do you wish to be a full code or no code? Mrs. B, oh, I don't know. I've never thought about this. I don't want to die. I still have relatively young children. So you want to be a full code? Yes, I guess so. Okay, that's the conversation. So that's obviously not a good conversation. Next. A resident looking uneasy enters the room. Mrs. B, has anything where it happened? Do you want us to do everything? I don't understand. Well, if your heart and lungs were to stop, would you want to use would you want us to use shocks to start your heart and put you on a breathing machine? I guess so. You mean you want me just to jump up and down and break your ribs and put a big plastic tube down your throat and do a lot of aggressive and invasive measures only to have you die in the intensive care unit? Oh, I guess not. Okay, so you want DNR status? I mean, these are not the right way, but these are conversations that we hear. Next slide, please. So what's missing? There's no discussion of goals of care. Both physicians ask the patient to provide an answer to a question about which the patient is not properly informed. And there are erroneous assumptions. The physician equates not wanting to die with wanting resuscitation. That's a big pitfall. That's not necessarily true. In this case, the physician knows CPR is medically futile and will not stop the patient from dying. The patient presumes that doing everything will result in a positive outcome. So I think these are really interesting examples of where we don't have appropriate conversations, because we haven't really been trained in how to do it, I think, is the reason we don't have these conversations appropriately. And so they make people uncomfortable. Next slide, please. Okay, so I mentioned earlier that we were going to go over the MOLST, so I think we should do that now. Next slide. So the MOLST is different than a healthcare proxy or a living will, because the MOLST is a medical, it's a physician's order. It is the only one of these advanced directives that a physician signs. That is the major difference. So it's an order sheet that has to be, by law, respected by an ambulance driver, the emergency room, the hospital, at home. So it's community wide. So when you're, someone calls, if you're at home and you pass out and the ambulance comes, they're not looking at your healthcare proxy. They're not calling your healthcare proxy. They're doing whatever they have to do to resuscitate you. Unless somebody pulls down the MOLST from the refrigerator, because that's a doctor's order. And this is the major difference. It doesn't have to be a limiting, it can say, I want everything, but it is an opportunity for you, the patient, to delineate your goals of care at the end of your life. And as I mentioned earlier, if we think someone is not going to live, if you would not be surprised that this person would be dead in 6 months for whatever reason, this is the time to have the conversation about the MOLST. So let's go through that. Okay, next. So I just took a picture of it. It's basically a hot pink form in paper, and now we're pushing more to have it electronically done because people can't find papers. And there is a website where you can enter these orders electronically called the eMOLST website. But basically, I don't know if you could see it, the first part talks about CPR and DNR. So you want it, you check off, I want to be resuscitated. You don't want it, you check off, do not resuscitate. The patient can verbally consent if they're mentally intact. Otherwise, you can say that the healthcare agent or the public health law surrogate, which we went over, or a guardian is the person that's making the decision. And then there are, you the doctor, sign it, or now it's legal also for a nurse practitioner to sign it. And the bottom section D is you just check off whether there are any other advanced directives that that patient has. Next page, next slide. The next section, section E, deals with other treatment guidelines. You could say you want comfort measures only, limited medical interventions, or no interventions. The next part deals with intubation. So you haven't, if your breathing is going down the tooth, but you actually haven't coded yet, would you want to be intubated? So like a COPD patient. Would you want a trial of intubation, or would you never want to be intubated, or do you always want to be intubated? Similarly, the next section deals with you want to be in a hospital or you never want to go back to a hospital. The next section deals with feeding tubes and fluids. You can say, I want a trial, I don't want a trial, I never want a feeding tube. And you don't have to check everything. You can just check off what you think you want to check off. Then do you want antibiotics or not? And then there's other instructions. You can write things in. I do want dialysis. I don't want dialysis. And similarly, the doctor and the patient or the surrogate or healthcare proxy signs it. Next page. There are 2 pages that look just like this, and these are for updating your wishes when they change, or when your circumstances change, or your health changes. So it's, again, something, it's not set in stone. I did this today, I can never change it. That's not the case. You could always change it, and you can always just rip it up. But it is generally a very good document to go over with patients who you think might be dying in the next 6 months. Okay, I think that probably was my last slide. Do you want to check, see if there are any more? That's the same thing. Okay, any more? That's it, I think. Okay, so that's really the end of my talk. Does anybody have any questions?
Thank you, Dr. Paris. We do have a question from Shirley Gerard, Dr. Gerard. She's asking, what about patients who actually live in another state, Connecticut, New Jersey, and get care in New York, for example?
And they get what?
Care in New York, for example. Care, medical care.
Here, they live in another state and they're getting care in New York? Is that the question?
Yes.
Are you asking if these documents are cross state lines?
Right, right. That's my question, because a lot of times people go to other states for their care and don't know that they have to have legal documents done in different states. At least that's how it used to be. There was no reciprocity because the documents were all state law.
I think most states recognize the health care proxy forms, and the medical orders is I think in every state. In some states it's called the PULSE, which is the physician's orders for life-sustaining treatment.
Right.
The living will is not legal in many states, but it is a valuable document because it's a person's expression of their wishes that a healthcare proxy or a doctor can look at to see what those values are if those conversations were never had. I think what